Friends, I welcome you all for this instruction course. We have good faculty here. Dr. Nitin Trivedi with me, who was past president of the Oculoplasty Society and presently practicing in Ahmedabad. He runs a good fellowship program for the past many years. Another eminent lacrimal surgeon, Dr. Ishan Acharya, also from Gujarat, from Baroda, and who is one of the few ophthalmic surgeons successfully running endoscopic clinics at his place. And the fourth faculty is Javed Ali from LV Prasad. We have divided the instruction course in 4 sessions and kept enough time for discussions, and questions would be appreciated, and it would I believe it would be a good round of talk. So coming to congenital dacrocystitis, basically the lacrimal passage starts as an ectodermal invagination which forms a cord, and this cord then canalizes to form the lacrimal duct. Anomalies, a variety of them, but most common is obstruction at the lower end where the duct opens in the inferior meatus. Others are like the duct opens in the non-canalization or opening in the bone, whereas the most commonest is imperforation of the Hasner's valve at the lower end. It's extremely common. About 25 to 30% of newborn infants, the mothers complained of some other form of epiphora. However, it's symptomatic in 6%. Interesting study by Casadi showed that 70% of stillborn infants have NND obstruction. That means the duct opens up at the very end stage of the gestation period. The good thing is that there is a high rate of spontaneous resolution. About 80 to 96% of the membranes, they open up by child's first birthday. The diagnosis is very obvious as soon as we see a child in the clinic. Carefully observing, we'll see excess, the tia meniscus height, excessive reflex from the cornea, which has blocked obstruction. It's important to closely and carefully observe the child, because the moment we go close to the child, they start crying. So, very important to have an examination as soon as the baby walks in the clinic. Many a times the diagnosis is very obvious with matting of lashes, discharge, and purulent regurgitation on pressing over the nasolacrimal duct. Another not very uncommon manifestations are swelling in relation to the lacrimal sac as seen in these pictures. Rarely we might come across newborns with swelling over the medial canthus, which is because of amniotocele, baby born with obstruction both proximal and distal in the lacrimal passage. What we always see is not true. So, these are not the true legs of these nuns. Basically, they are sitting on stools. So, not every swelling on the lacrimal sac region is a blocked duct. These are child with hemangiomas. On first look, probably misleading to be NLD obstructions. Wherever in doubt, a dye disappearance test is very helpful and very simple. Installation of fluorescent drop in the eyes, cleaning the excess fluorescent, and send the baby out. See again after 5 minutes, and in a dark room with blue light, we can see the poor drainage on the side where the obstruction is there. The Cause of necrocystitis remains controversial, whether it's obstruction which leads to infection or primary infection which later on leads to infection and inflammation and obstruction. Various studies which have quoted common organisms who colonize the lacrimal passage. However, the exact relationship between the pathogens and the cause of obstruction is still doubtful. Most cases can be managed without imaging studies. However, necrocystography can probably identify the level of obstruction to correlate with the success rate for the procedure to be performed. Ultrasound is helpful. It's a non-invasive procedure, doesn't require much cooperation from the patient, and wherever in doubt, as we see here, this to confirm that it's a cystic cavity, we see a hypoechoic lesion over here with reflectivity correlating to a cystic space over there, which confirms the diagnosis of necrocystocele. Occurs in about, they have given the study quotes about 14 to 75% of patients, but probably we don't see that frequently in our clinic. Probably in my practice I must have seen about 8 to 10 patients of necrocystocele in past 14 years. Important to differentiate from meningoencephalocele, hemangioma, pneumatocoele or sac tumors. The goal for management is prevention of infection and open the obstruction. Role of antibiotics is doubtful, but still, it's always advisable to start some antibiotic drop at least once or twice a day to prevent secondary infection or the infection leading to acute stages. Medical management has been the gold standard for nasolacrimal duct obstruction. A high success rate, probably we all are aware. Only thing is proper technique of massage, explaining the scientific reasoning of massage to the mother, and I specifically see to it that I explain the mother how the massage has to be done and explain them the scientific reasoning. As I told earlier, it's to develop the hydrostatic pressure on the sac area, and probably this wave might open up the obstruction. Tell them that has a very high success rate. If done religiously, the child might not have to undergo the small surgery that probably would be needed if this doesn't opens up. A historic paper by McEwan and Young, which shows the rate of spontaneous remission decreases as the patient grows up. I did a study on patients and found, very correlating to the results published. But still, what I would stress is even in children 6 months and above, we see the success rate of spontaneous resolution is that high, 84.5% in 6 to 12 months, and say more than 12 months, 21%. So I personally feel that unless there are social indications or the parents are anxious about the watering, or we see that there is sac infection or there is a lot of purulent discharge, medical management can be given a try. Most of the time it's the massage which has not been done properly. I agree that 3 to 4 weeks of trial is fairly good enough and obstruction should open up, but most of the time what I have found on properly taking the history from the mother is neglect in the technique of massage or treatment advised. Probably they are not taking it as we demonstrated. So medical treatment definitely does has a role, no hassle, no hurry. But if the parents are keen, anxious, they want to get rid of the condition, we know that's a very simple procedure, not much of hassles in it. Definitely probing can be done at an early age. advent of nasal endoscopy is a boon for lacrimal surgeons. I understand that not all of us have an endoscope, not all of us have the zeal to start with endoscopy, but time has come to gradually take the endoscope in a hand and start using it, and it does have a beneficial role in managing patients of lacrimal disease. Failure of conservative management, probing. So it's that risky, probably without an endoscope, or wherever we are starting with the procedure in the early days of our career, there is a very narrow margin. The baby's eyes are not fully developed. The lacrimal passage itself is very delicate structure. So always to keep in mind that there is that narrow margin whenever we are working on the lacrimal system. Well, to say that it's a blind procedure might not be true in today's era, but yes, most of us do it without an endoscope, and I don't say that endoscope we cannot do without endoscope. With experience it's possible and has a good success rate, but effectively we can say that it's a blind procedure. Good study by Hussain et al., and they have quoted 44% incidence of canalicular stenosis after false probing. So always keep this in mind. Various sizes are available. I always start with a 00 probe, which is about 0.9 millimeters, and once probing is successful with the thinner diameter probe, we can reprobe them with thicker ones called as stepwise probing. And following probing, always useful to irrigate the lacrimal passage to confirm that we are successful. Two school of thoughts, the early office probing versus the conservative management and late probing. More and more lacrimal surgeons of our era now probably believe in late probing, where giving conservative management its own duration to get the passage open. I don't think we now probe the baby without anesthesia. I don't think anyone in the hall here have been doing probing without anesthesia. Anyone? I think earlier, again, two school of thoughts. Early probing, definitely we avoid the morbidity related to general anesthesia in a small baby. And supporters of late probing have their own say. But definitely, in older children, GA is a must. Probably child's cooperation is, we cannot expect cooperation from older child, and they resist more. So various authors who have given a good success rate even in higher age groups, this is very encouraging. Video which shows why probing fails. Has to pass, the people move around, the train passes, and they again run a very busy market here. So it's something like this where whenever we pass a probe, definitely the membrane opens up, but the flaps again close down. Probably I think that's something which might be the reasoning. Many times we see that even after successful probing, Baby returns back with mother complaining of epiphora. We now know that possibly there are two types of obstructions. One is the simple obstruction, the simple membranous, and the other is a complex type of obstruction where there is a length of narrowing of the duct, and probably these are the one which not open up by medical treatment, and definitely, as we see here, they need some surgical intervention. Causes of failed probing, yes, we can blame it on our colleague, but probably not done properly, or reclosure of the Hasner's wall, or a complex type of obstruction. Alternatives, intubation, dacroplasty, dacrocystorhinostose. Obviously, reprobing before all these interventions. Celastic intubation has a high success rate. Technically difficult. Causes of canalicular injury being reported after intubation, and second surgery being required, second anesthesia being required for removal of the tube, and yes, the tube has to be left in place for a longer duration. Interesting paper which shows the tubing should be left for a longer duration, but not more than 12 months, but definitely, I think it's about 3 to 6 months of time is a variable, is a fairly good amount where the tubing is to be left in place for it to open up. This is a technique which we borrowed from our cardiologist friend. It's the same technique, same method, and first time the procedure was out by Becker and Berry. West, more and more lacrimal surgeons prefer doing it as a primary method, but we know that it's not required. The success rate for balloon dacroplasty and stenting has been found neck to neck. There was one concern amongst lacrimal surgeons about the effect of balloon dilatation on the nasolacrimal duct, and this shows that it does not cause crush injuries in the nasolacrimal duct. So yes, it's a safe procedure, not causing pressure necrosis of the duct. So this is a schematic animated view which shows uninflated balloon in the duct, and this is when it is inflated. So this causes true dilatation of the nasolacrimal duct, which is required. And as we recollect the earlier image where I showed you the complex type of obstructions which have a longer segment which is narrow, and this is very scientific that the balloon will cause true dilatation of that narrow region over the lacrimal duct. This is an inflation device. This is the balloon catheter. This is the inflated catheter, and it has two marks. These marks help us in knowing the position of the balloon when it is in the nasolacrimal duct. Once the catheter is in place, it is inflated to atmospheric pressure of about 8, and it's left in place for about a minute. And after the procedure is done, we irrigate the lacrimal passage to confirm the patency. auscultation device. Primary probing with a Bowman's probe. Once this opens up, now these marks help us know where the catheter is in the lacrimal duct. So the upper mark is about 3.5 years or 4 years old, and he had 2 failed probings, and it was finally we were able to open up. All the decroplasties that I did were in older children, and all were complex obstructions, and had a good success rate of about 90% as far as I recollect one of my old papers. Finally, the last resort is decrocystorhinostomy. Pediatric decrocystorhinostomy is slightly difficult because of technically difficult because of underdeveloped face, the narrow space to work on. But result wise, it's equally good, success rate is equally good. 3 years and above, definitely if everything fails on, DCR is as successful as an adult. There are reports of DCRs being done in younger children also. Probably I have not intervened in child less than 3 years, but it can be done, and results are equally successful. So finally, stepwise treatment paradigm for nasolacrimal duct obstruction should be followed. Medical management has important role, and I think I've stepped over my timing. Now I invite Dr. Nitin Trivedi